levels. So there's need to integrate data from a patient from level 1 to the level at which they are accessing care. So if there's community health data, ideally that data needs to make its way to become one central place where you find a patient's record. The third, at the front line, everything starts with the patient and their care provider, which means that the provider needs to be sufficiently supported to take care of the patient, and the patient needs to be comfortable that they will access their own data. For health managers, they need data that for them to orchestrate the pillars of the building block of health for the benefit of patients, and rely on this data to manage health workers, commodities, etc., so that all these are available to the healthcare worker who is taking care of their patients. And then, of course, for public health, most of us know that during COVID-19, our health system, data systems for public health failed, and these need to be addressed. But then, if you go to a facility, you will find, for example, you have a very fully digitized HIV clinic, where records are being done electronically, and the clinicians have at their disposal data for almost 20 years of a patient's care. But then you go to outpatient, and the story is very different. Same facility, different scenarios. It's like the facilities are schizophrenics, right? You cannot imagine that in the HIV clinic, you're finding machine learning models running, but in the outpatient, it's inefficient. So the health system has fragmented patient records over many years through a systematic process that we need to now undo, okay? What that means is that these siloed systems we were developing needs now to be consolidated into something that gives providers a 360 view of patient's care, regardless of where they are receiving care, and not just monitoring diseases in patients. Now, as we begin our digitization journey, we need to build on these past investments. Kenya EMR, for example, has a footprint across many facilities, across many counties. And by enhancing Kenya EMR to become facility-wide, you start from a point where you're building on what exists. Systems that are open source allow us to make sure that you can be able to invite other public health practitioners, other program implementers, to start building their programs around a sustainable, free and open source solution that makes sure that the programs are sustainable beyond the period of funding. Now, what does this mean what does patient-centric care really mean? Okay? To a patient and a provider. To a facility, it means that how your facility is configured, you need to be able to provide services digitally. Because if part of the facility is using paper, the records will be fragmented for sure. So for us, what we had to do is to make sure that the facility administration that monitor revenue, commodities, and health inputs are supported to digitize their operations, but also do this at the lower levels of clinical care. We realize, for example, there are almost 28 special clinics in a typical facility, and these have to be digitized. Otherwise, for the higher level facilities, they may not be able to operate effectively. Kisumu is one of the counties where we are digitizing. Currently, we have 24 facilities that have been upgraded with facility-wide capabilities, and around 13 are currently using the EMR as facility-wide. Now I'll go to what does Kenya EMR really do, so that I ground some of the concepts we have presented since yesterday in a practical implementation. So this is a typical facility where you can see that the system allows queuing of patients depending on the level of priorities for that patient. Providers can check in patients, see what they're waiting for, and know how many minutes they're waiting per day. And you can break this down by the time a patient is waiting for service and actually the time the patient spends in service. You can look at a patient's profile, and I want to highlight just 3 areas. On the left-hand side panel, you will see the number of special clinics that Kenya EMR supports, aside from the general clinics that a patient would go for. You can see the pink-colored flags. These are alerts that tells a clinician, you don't need to know the cholera case. The system will be able to automatically compute when they see a case of cholera, malaria, and many other diseases, so that then the provider takes efforts earlier. Then at the end of the day, retrieving patients' record is made easier. Instead of looking through voluminous files like happens in many outpatients, they can actually electronically retrieve that data. Then on the right-hand side, alerting providers of emergency whenever, for example, a temperature is out of range. So that's one area I wanted to talk about. Then the second thing is shareable health record. Dr. Deutsch talked about the digital health superhighway. How will you get your data from Chulaimbo Health Center if you are visiting JOTRH? It means that the facility that saw you in Chulaimbo should upload your record to the shareable health record. And then the team at LRDHC, with your consent, should be able to pull that data so that your referral details are accessible. And that, on the right-hand side, you'll see there's a one-time password that clinicians can actually prompt you to enter, so that then you can be able to access your records for continuity of care. And on the lower side, for example, in this case, this is a patient who is allergic to aspirin. So the provider in LRDHC will be able to see that this patient is allergic to aspirin and take precautionary measures when doing their prescription. Community referrals is supported. But what you need to see in this particular case is that in Kenya EMR, once you check if there are any referrals for yourself, you can actually be able to pull those referrals and initiate services to those patients as needed. Then the next thing is just billing and e-claims. So there are three scenarios we see. As you take care of a patient, the bill should automatically be generated so that at the end of the encounter, the facility, whether they use cash, M-Pesa, or they want to claim from insurance, the system automatically creates for you the e-claims form. What I've noticed with the rollout of SHA, for example, at the moment, is that providers have to see patients during the day. Then at the end of the day, you start remembering which patient you saw, fill into this portal so that they be reimbursed. That is extra work. With an EMR system, you can actually automate that process. And remember, the e-claim system Dr. Joyce presented is part of the digital health superhighway. Okay? So this makes it easier for facilities to process their claims efficiently and reduce the burden of paperwork that they need to do. And then finally is on inventory management. Before I go to the last set of slides, Kenya EMR has a stock management module. In the facilities we are implementing in Kisumu County, we are now thinking about how to retire some of the legacy dispensing tools so that then the provider interacts with one tool and then shares data to the other dispensing tools for the purposes of program planning. This is important because you need end-to-end visibility of commodities if you are able to monitor and avoid service disruptions. Then the second last bit of slides is facility dashboards. Most of us in the health sector, we have two categories of people: those who see patients at the front line and those who offer management support. Those who offer management support need to have intel about what's happening in the facility at their disposal. This is a sample chart from some time back, which tells them how many patients visited the facility, and you can incorporate in efficiently metrics within it, so that at the click of a button, the governor, the CECs, the chief officers can be able to see the health status of their facility at a go. Last but not least is machine learning. Currently, if you go to a Kenya EMR site, we have 2 machine learning models embedded within the EMR that do not require internet for a provider to access. This means that it is possible that those who are having data innovations can actually integrate within Kenya EMR, so that then you can create intel to providers at the front line, but also generate insights to tell the county or the country where there are hotspots for disease outbreaks, for HIV risk, and any other diseases that come up. And finally, when I stick to the data theme, this is a sample dashboard in a national data warehouse that the Ministry of Health manages that tells you adverse events relating to medicines. It's telling you what the providers did when they experienced the adverse events, so that then you can also look at the quality of care that has been given to that patient. My final remarks on this matter is that we are looking at a transition to a patient-centric system. You must integrate data for a patient, but also allow stakeholders who contribute to the patient's care either directly or indirectly through funded programs to participate and get accommodated in the digital health system that is being used in each facility. Thank you so much, and that's the end of my presentation.
Asante sana. Thank you very much for your presentation. And swiftly, we proceed to our next order of business, which is a panel on matters innovative financing, funding the future of digital health. And in this panel, we understand that sustainable financing is a key pillar in achieving digital health in our day-to-day life. But the big question is, what are these opportunities, financing models, traditional ones vis-a-vis new ones? At the end of the day, we're expecting to see from this panel some innovative financial mechanisms for Kenya's financing of digital health landscape. And who better to moderate this session other than the one and only Director, Health Systems at Farm Access, Dr. Kwasi. Mpigeni makofi tafadhali hadi afike daktari. Yes. White looks good on you. Keep doing it, all right? Enjoy.
Most countries in sub-Saharan Africa face systems failure in
health. Thank you very much,
the healthcare
MC,
systems
for
in these
nice words, and thanks a lot for all those who've been here. The room is packed. We're going to have a conversation on innovative financing. The MC already explained it, so for the sake of time, I won't go over it. I understand that you're going to play a short video, so if you could start with that, that would be nice.
Most countries in sub-Saharan Africa face systems failure in healthcare. The healthcare systems in these countries are caught in a downward spiral of poor supply and demand that leads to inequities. When people cannot rely on the system, they feel they can only rely on themselves. Since 2001, Farm Access has been working to create this virtuous cycle of trust in healthcare in partnership with the public and private sector. Because society benefits when healthcare is organized collectively. Today, we see a new reality emerging in healthcare. Connectivity and data are the catalysts for more resilient healthcare systems. They will enable us to accelerate how we build and strengthen the cycle of trust. We can fundamentally change healthcare systems when we put patients at the center through connectivity. We can help patients gain more control when their health data is available and entrusted. We can improve health outcomes when we make smarter use of this collective health data. We can make positive effects flow throughout the healthcare system when data become the currency of trust. Farm Access, we can make the impossible possible when we care.
Yeah, thank you very much. So we're going to have a conversation about the resources that we need to optimize the value of digital health. And I always begin, sort of a panel with some wise sayings, because I think they stick into our memory. And since we are in Kenya, there's a wise saying in Kenya that you cannot milk a cow with dry hands, meaning that you need some resources to go for it. And for our audience, visitors from Europe, the Netherlands, there's a saying that you need a wind to optimize the value of a windmill. So there are always resources that you need. For us to do this, we have a panel, and I will ask them to come to the podium. We have Dr. Tracy Jones, Acting Director on Health Financing from the Ministry of Health. And Dr. Amitaka, Executive Chairman, African Health Business. We have, and I'm not sure if the gentleman is here, Dr. Abdi Mohammed, Chair, Social Health Authority or representative. Okay, then we go to Peter Rickard, CEO KPay, and Dr. Okaka of Kenya Health Care Federation. Thank you very much. Yeah, thank you very much for coming for this panel. What I will do is I will interact with them on a series of questions, and then we will open the floor to the audience to have observations and questions, interaction with the panel. Dr. Tracy John, you are representing the Ministry of Health, and it's important that in conversations around financing, we put the discussion in a broader perspective. In October, when the government announced Social Health Authority, they said that they are committing 6.1 billion Kenyan shillings to ensure implementation. But we know that the full cost is around 164 billion. So the money from the government is only 4%. How do we close the gap?
Thank you very much. Indeed, in terms of resources that we require to be able to have sustainable finances, do require a critical approach because we know that we do have an increased demand for healthcare in the country, and we are faced with the changing times where we have a rising in the non-communicable diseases as well as injuries on top of the existing communicable diseases. And that means that with that increase in demand for healthcare services, the cost of healthcare then becomes more than what we had before. And moving forward, to be able to address that, we also know that we do have a need to accelerate the need to achieve universal health coverage for our people, so that we can be able to offer those services in a manner that is affordable and the quality of care is improved, as well as making sure there is equity in distribution of the resources and protecting our populations from financial hardship and catastrophic expenditure that comes with the spending at the point of source. So with that background, we do recognize that there is a critical need to rethink how we finance our health care from the traditional methods of having patients to pay from their pockets and the government to put in money in form of inputs, towards ways that can be able to not only mobilize more resources, but to mobilize resources in a way that is equitable in the distribution so that we don't leave anyone behind. And also to make sure that the methods we use to mobilize these resources are sustainable. Sustainability becomes very key. So that whatever we implement, then we're able to carry it forward towards achieving the UHC.
Yeah, thank you very much. Dr. Mitaka, you sit between the government and the people. So from the private sector side, you are also engaged in private sector. And I want to have your perspectives on, through your interaction with the private sector, but also on the public-private partnership side, the developments happening there to ensure that financing can be there to talk about all these aspirations, implement all the aspirations that we are hoping for will come out of digital health.
Like Tracy said, Kwasi, financing on the health side, UHC or any other innovative ideas is very tricky, we all know. And not only in Kenya, but across the entire world. We need more money for health, but we also need more health for the money. So those two need to work in parallel. So the message to the government is, let's have efficiency very critically designed so that the level of trust goes up and more money for health will come from all stakeholders. But if we're not getting health for the money, and there are inefficiencies, we need to work on that very quickly. Because every citizen in any country and any stakeholder, be it private sector, donors or development partners, will not want to provide any more funding if they see some kind of inefficiency. So that's the fundamental principle. And the principle of trust is non-negotiable. Be it NHIF, be it SHIF, be it SHA. So fundamentally, we are dealing with a superb transition in Kenya. What we need to do is to get the basic concepts right, that the money will be used appropriately. Of course, you talked about 164 billion. We know that we have a very small formal sector, and the formal sector is going to end up paying even a multiplier of 15 towards health. And the Kenyan population is amazing. They've moved ahead. They have registered. Companies have put in the system. You are going to get a multiplier effect of people paying 2.75% of their salary when they were paying a cap of 1700. But this small population isn't adequate, Kwasi, to provide the full funding. So we need to divide it into multiple segments. So it's private sector, it's informal sector who will have to be identified, the means testing, which is not so easy to do, and then we have donors and partners. So my opinion is it's only through collaborative partnerships that we can achieve UHC. If we find that it's going to be a single funding source, it's going to be very impossible. And that's why many African countries are thinking of strategies. Let's look at Ghana. You know the country well. They've used health tax. Every time you move outside, there's a 3% health tax that still exists. There are some countries that have used VAT as a leverage. There are other countries that have used sin tax. Rwanda has used a larger government funding. So I think each country designs its own financing. For Kenya, I think we've agreed that it's going to be a mix of public and private. It's going to be a scale which is dedicated for formal sector using payroll tax, and we'll have a contributory scheme and means testing from an informal space. My view is that as you grow, you build trust in the system, and you'll find more investments and targeted investments in UHC. Thanks.
Thank you very much. And I agree with both that you need to ensure efficiency, you need to ensure sustainability, but the bottom line is you need more money. Yeah, because the deficit of 96% has to be financed. And there are people in the country that cannot pay for health. There are people in the country that can also pay for more than they consume, right? So it got to come from both sides. Now, we heard Peter from two previous speakers that it's not just about throwing money at the problem, but optimizing efficiency. So from your viewpoint, what are the prospects of using digital technology to achieve that? And you can certainly speak from the work that you've done for KP.
Okay, thank you, everyone. Happy to comment on that. From the MTIMA side, we've seen firsthand that a lot of innovations are possible. But I was also tempted to maybe make a statement that, innovation sometimes sounds very advanced and complex, and it's tempting to do everything super advanced. But in the end, what will make things a lot easier and better is just by paying fast, because it's as simple as that. So if the hospitals are paid faster, the rates can be better, and a lot of the problems in the sector can be addressed. And technology can really help with that. So think about like automatic claim submission, digital claims assessment, digital claims payment, which is all applicable both in public and in private space. As MTIBA, we're mostly focusing on the private space now, but there we see that that really has tremendous effects. So essentially claims can be paid 96% faster than before. So where it previously took like 3 months, 6 months, now it can actually be done in a few days. Insurance companies don't want that, just to be clear, because they do want to make a return. But still, paying on at the end of the month is still a massive difference, where hospitals previously had to wait. So by making that more efficient, there's going to be less money captured into the system, where working capital needs to be financed because doctors need to be paid today, medicines need to be procured today. And if the payment for the services rendered only comes in like 3-4 months' time, then that leads to massive inefficiencies. So I think paying fast is the big one. And then the second one is the real-time data that all of these systems that everyone is working on can create. That really informs decision making. So where is the waste happening? Where is the fraud happening? Where is over-servicing happening? Where are people going to expensive facilities for simple services? So data can really help with making sure that technology can be a data partner to the decision makers. And I think it's a combination of both. So data as a solution or tech is not the only solution. It's about what you do with it and how you act on it. So,
yeah. Thank you very much. Dr. Okaka, representing Kenya Healthcare Federation. You know, the private sector plays an important role. And 50% of the care, we understand, is delivered by the private sector. If you go to Asia, it's even higher. And you are also at the end where you are receiving a lot of payments for the services that you deliver. So you cannot be left out in the conversation around efficiency and getting cost down. Share with us the experience from the Kenya Healthcare Federation side in this journey.
Okay. Thank you. Private sector, looking at, as you said, half of healthcare in Kenya, sort of 12,000 facilities, 6,500 are private. But from a digital health standpoint, we find ourselves thrown into the deep end of things, for example, with the changes that government is trying to implement. So we have a Digital Health Act that was passed, and someone yesterday took us through the digital superhighway, the digital health superhighway. And what we are saying as private sector is we now need to look for funding to finance full digitization of the private health sector. And when I speak private health, maybe we should also stop thinking the level 5 and 6 private health centers. So if you're a clinical officer and you're running a facility, second floor of a building, you're in private healthcare. If you're a nurse running a small nursing home somewhere in Central Province, you're a private healthcare provider. And now you need to digitize your service to either get Social Health Authority onboarding, or very soon, if you want to get, say, CarePay, right, MTBA, you need to start thinking, how do I digitize my business? The question then becomes, where do I get money to do that? It's highly cost intensive. You're talking anything from $50,000, $30,000, $50,000, all the way to a large private facility in Kenya implemented their system at almost half a billion Kenya shillings. So these costs are there, they're varied. What we are trying to figure out now as private sector is where do we get the money to do this?
Thanks a lot. So there are two aspects to the conversation. There is the financing of services for people who, whether it's insurance or for people who cannot pay, whether it's subsidy from the government. And there are the investments that we need in the infrastructure. Yeah. So on the financing side, we've seen massive gains in efficiency. I thought you were a bit modest in not mentioning some of the figures, because I know that those who are using your platform, the providers, they've been able to have about 15% cost reduction.
Yeah, that's correct. Sorry.
Yeah. I also know from work that Pharmacists does in Ghana on digital health for NCD patients. And patients that are using the digital health have been able to reduce their cost by 20%. because there's no need for a patient to travel to the hospital to be told that the doctor has gone to a funeral, right? That's an extreme case. So you save transport cost with that. The other part is that there are measurements that you can send online. The medical professional, they look at it, they advise your situation. So that's massive gains. And we all applaud the value that we get from digital health. Amit, you are still the link between us and the government and, getting things moving. If you look at the mobile telecommunication companies, they've done marvelously well. They did not start one day going big. What are the lessons that we can learn from there to help us around this conversation with regard to financing of digital health?
That's a very good question, and I think we need to learn from the mobile tech industry the value of collaboration. And I think healthcare is getting there. Many times we find ourselves preaching to the converted and the people who know, and we talk amongst ourselves a lot. What Safaricom did and what others did, they started bringing in the Ministry of Finance way early. I would love to see them here. I would tell Geoffrey that it would be great to have CEC Finance of Kisumu County here. It would be great to see CEC of ICT. What we need to learn from the other industry is how to have deeper collaboration for our products and services to reach the people. If we want healthcare to reach the community, from telecom, we learn bringing other stakeholders. Let's get financing on the table. Let's get other policymakers on the table. The second thing I think I've learned from the telecom industry is not everything which is from developed countries can be copy-pasted and work in developing countries. That they did amazing. So what may work in other countries does not necessarily mean to work here. Reverse innovation, showing the rest of the world what can be made in Africa so that the other countries in the world benefit from us, is really what the M-Pesa story is. We have created a much more robust mobile system engagement than any part of the world. So reverse innovation can also work. Rely on what your needs are, develop solutions that are tailor-made is another thing we should learn from the telecom industry. The third is how to get paid for your innovation. That's the medical services you were talking about. Quite often, I think in healthcare, we work on giving ideas, but we don't see through who's paying for it. In fact, we come up with ideas and say, this is great to have. But I keep saying, a gap in the market does not mean there's market in the gap. And if you think it's a brilliant idea, but there's no buyer, and nobody's going to be able to pay for it, then you need to think differently. And that's why we needed to think per minute billing. Do you remember per minute billing for your phone? And then somebody came to give you per second billing. And all these telecom people were fighting for the right price. And guess what? The better option continued getting the better clients because they went per second billing. And I feel that if we get the pricing right and we get our communities to understand how it can be paid for, then there's less burden on the government saying government should be providing us free health services for all. It just cannot. I mean, let's find. So I feel those three lessons from the telecom industry are things we can learn from.
Yes.
Thanks.
Yeah, thank. Dr. Tracy John, at the government side, could you share experiences on collaborations that you've seen and have yielded results or going forward that we can leverage on to close this gap. And I'm also interested in efforts being made around the informal sector.
Thank you very much. Indeed, the source of financing has to be looked at from a multi-sectoral perspective to be able to mobilize those resources that we need and in an efficient manner. And that's why we do have strategies in place where we're looking at other sources. And one of the key areas is in the public-private partnerships, where we look to mobilize resources, especially in the areas that are very capital intensive, like medical equipment, whether it's infrastructure, in the digitization platform, looking at how we can be able to tap into the resources that do exist in the private sector and other players in the market to be able to bring on board what we need. And that is a model that has been going on. We do have the legal frameworks and the implementation frameworks that support the partnerships, and this is an ongoing area of mobilizing resources. When we look at even the health insurance, where we're moving towards mandatory insurance for Kenyans, there's a recognition that it can't all be from the social insurer. We have to tap into also other players in the markets where private health insurance then plays a complementary role to be able to also provide that very much needed financial risk protection from the other share of the market. And that goes a long way in reducing the burden in terms of the financing of care from the government side. And also the digitization, also we can't not mention that because it's already established, and we do recognize that that's an area for us to reap big in terms of efficiency gains and also reducing the cost of care. And that's why even in the new model of social health insurance, digitization then plays a very key role. And also looking at how we can partner with the sector, the private sector and other players towards other digital health solutions that can help to provide quality of care and bridge the gap, especially where there's a shortage of human resources, because then we know it's going to not only reduce the care but also improve the access and the quality that of care that we provide to our populations. So those are some of the areas that we look at. And also, as far as efficiency is concerned, prioritizing interventions that have been documented to be of low cost and high impact interventions is very critical as far as efficiency is concerned, which informs the need to prioritize the primary healthcare services and making sure that these services are available to all persons, whether they have been able to contribute to health insurance or not. And that's an area also where the partnerships can come in to bring promotive and preventive as well as rehabilitative interventions to be able to expound on that and to lower the cost of care. Because we know if we are able to tap into that, then we can reduce the cost that goes into the social health insurance or the higher levels of care, because then the need can be brought down. People can stay more healthy, and we can reduce the escalated cases that really require too much resources. So those are the interventions that currently we're looking at, and others that are also in the pipeline. Thank you.
No, thank you very much. Priority setting is important, and do things that count matter first. And I think it's also what we've learned from the telcos. And with Amit's example on phased intervention and learning from it and building on it. Peter, unfortunately, for unforeseen circumstances, will have to leave before the end. So Peter, before you leave, when we deploy, it's an interesting conversation in the sense that you need investment to do digital health, but the digital health itself will also bring cost savings and generate more investment. And when you do all these things, you know, the expectation, and we've seen, is that you certainly improve patient outcomes. An important ingredient in that is data. Getting data, leveraging on it. And again, from experience, what has been the value that we've gotten so far.
Okay, thanks. I think maybe there's a couple of things I can highlight in response to that question. So I think it is clear that data can really help with efficiencies and cost saving, like we spoke about before, and helping me with remembering the statistic of 15% cost saving. Indeed, that's correct. Another aspect really is, I think, the experience that people have in, the customer experience, or how, because in the end, patients are customers as well, and they need to make sure that they are being treated well, not only from a healthcare delivery perspective, but also in terms of the experience, so that they continue to seek services in an efficient way. So digital technology and data can also really help with that. Real-time customer feedback, making sure that things are done in the right way. But I think there's another element that I would like to highlight, which is slightly different. It's in terms of like the financing of healthcare expenditure, because we've been talking about like how do we, find sources of public funding, private funding. I think there's also an aspect where we can, make sure that healthcare expenditure and insurance covers become more intuitive, and that people are actually understanding that they can pay for that very easily and efficiently. And technology can help with that. So I had to think of some of the products that we develop with partners. So one of them is, for instance, an innovative insurance cover embedded in a digital, or like in a battery of an electric motorbike. So there's currently a motorbike company who has batteries, and whenever the motorbike rider, the Boda rider, is going to refuel, it's essentially swapping a battery. Now, through the use of technology, it's possible to embed an insurance cover in that swap of the battery. So every time that the Boda rider swaps their battery for, I think, 299 shillings, they have an embedded healthcare cover for 72 hours for 10 shillings. So imagine a healthcare cover which is so intuitive that you buy it without noticing that you buy it. And that it's only priced at 10 shillings, which is an insanely low amount. So it's only possible if you use technology to make sure that the data can be used, first of all, to manage risks and to understand risks. Because everyone has intuitively the feeling that Boda riders are very risky. But they're not, actually. They're very careful. And so, especially in urban settings, Bodas are relatively okay. So the data will help you price it right. And also the data will help you essentially administer it efficiently. So I think this is an example which came to mind that I wanted to bring forward.
No, thanks a lot. Thanks a lot. So it's about inclusive healthcare, right? So when we talk about inclusive healthcare, then it's also about all the possibilities that we can leverage to bring in resources to make it work. And so just an example from Ghana, where, as Amit said, they are using VAT. So when you buy something, 2.5% of the VAT that you pay will go directly to the insurer. And the insurer will use it to finance care, in addition to the monthly deductions of 2.5% made from the pensions of people with former jobs. So if you work for the government, you work for a private sector, every month, your pension, they take 2.5% of it and put it in insurance. Whether you use the insurance or you don't use it, they have taken the money. A lot of people also have private insurance, but they say that the national insurance is for all of us. So you can see the national insurance as basic insurance, and then you can have your private to top up with the complementary. So I think it's an important development. I also know that Kenyan government, as part of AU, is also partnering with the Dutch government on a program of improving efficiency in tax collection, also in the informal sector. And so at the AU level, they have the African Tax Forum, where they are making all these developments. Because, a greater part of the money is out of pocket. So if we can really tap into it, we can make everything, profit. Not really profit, but business making. Dr. Okaka, it's a difficult question I'm going to put to you. Normally, this should go to the government, and when they talk about sustainability, and then they have the opportunity to talk about all the good policies that they have. But I think on the private sector side, it's a different story. Sustainability. How do you see that from the private sector perspective?
I think the private sector is untapped. If you're thinking healthcare financing, let me stir up some dust. Usually when you want to start a business, any business, you're told it's in 3 Fs, right? Families, friends, and fools, right? And then you have to go to more formal financing. So we are talking about the formal financing here. So it's either equity-based financing, meaning you give someone a piece of your business, or then debt financing, where you go to a formal institution and ask for financing. Now, Amit has said something interesting. We need to have CEC Health here, and CEC Finance, CEC ICT. I think we also need to have the banking sector here, because we are speaking to financing. Where are they? They are the most formal form of debt financing we have in the market. Do they understand healthcare? If I want to take a loan to purchase a lab information management system, how do I get the credit for it? How do I structure it so that the bank understands the efficiency savings I'll take from CarePay or MTIPA, that is a value add that I have that I did not have before. So that then they're not looking at traditional asset classes and say, you need to take it out based on a physical piece of equipment or the land you have or something to that extent. What I challenge government to do is pretty simple. India did this before. They noticed banks were lending to specific high net worth individuals, which is happening in Kenya. The high net worth individual being government itself, again. So banks are preferably buying treasury bills and bonds for obvious reasons. If the government wants to stimulate healthcare financing to the private sector, they hold fiscal policy as a tool. And it's up to them to come up with legislations that say, I ask a credit facility. If you're a bank registered by CBK, I expect 2% of your asset book to be in the healthcare sector. Let the banks figure it out who they lend to. But that forces formal institutions to innovate and to start thinking, hey, if we have made a decision as a country to invest in healthcare, how do I make my 2% work within the healthcare space? So that's the challenge I'd pass to government. Back to you.
Thank you very much. Thank you very much. I would now like to ask the participants, audience, observation, comments, and then we'll bring this to an end.
Thank you very much for the stimulating discussions. My disappointment is only one, that the focus is on illness. And we've traveled a lot of miles to come here to talk about illness, which we know very well. You're sure that Amin Thacker goes to a chemist and picks his diabetic medicine and also his hypertensive medicine, and to some extent his other medicines. But health is not drugs, hospital. What about what actually brings in health? And if we go backwards to the COVID-19, for the period that COVID-19 was in place, I can tell you, I know pediatricians, I don't want to mention them by name, who actually closed their clinics. Why? There was hygiene practice, there was hand washing, there was masking, there was keeping your distance. But we're not talking about this. In terms of the role of technology for information to improve this and how to enhance. And after the talk, you hear a lot of good statements about sustainability, expensive. In fact, as you were talking, I was imagining if this room was full of grandmothers, what kind of language would we talk to them about what we are trying to convey so that they also become a major participant in our work today in improving health and utilizing technology. We need to incorporate that. We missed the boat.
If you can keep your observation or comments very brief.
Very short,
I will
actually.
appreciate
Thank
that.
you very much, Dr. Just to say that I am a grandmother, by the way. So, but importantly, I think that in a lot of discussions, there are so many ideas, brilliant ideas, and so many solutions. And Amit, I liked what you talked about, what you said in one of your sentences, collectiveness. I think that is what is key. And today, you know, as we went through the corridors, there are all these brilliant ideas, but everybody's working in silos. How do we harness these important ideas, you know, for the betterment, and also to reduce on, you know, the costs? You know, so this one comes in with this solution. Ministry of Health Kenya, I have this solution for you. Another one comes with a different solution. It's really confusing the space. How can we harness our ideas? Thank you.
One more.
One more? Oh, okay.
Thank you very much to the panel for the exciting and very important deliberation. My question, but it's just an echo of the first question. I'm sorry I'm repeating it. Maybe I dozed and I didn't get it. And it goes to the director. There was a gap. And the question was, how are we going to fill the gap? And I thought it was going to come in bullet. First bullet, second bullet, like this. And this is based on the experience. Now I want to come home, Kenya. And we have lessons learned. You want to do something about it? I just raised my voice. We simply go to the lessons learned with NHIF. As we were winding it up on 1st October or whatever, it was in debt. So the issue of sustainability should really make us dig deep into the financing of the next one. So these bullets should not just be what it is. From what I gathered in the discussion there was taxation and I don't know what and what. I think it was just taxation I had. So, we know how we will fill that gap.
Yeah, thank you very much. So what we try to do is to make this conversation not aspirational. Yeah, because when it comes to aspiration, you can have a whole lot of things that should happen in the future. And we try to look at what we have done and how we are building on that. And so the point about the gap, and coming to Dr. Rai on the gap, is a gap that is there to improve healthcare, whether it's prevention, it's treatment, it's biomedicine, whatever, that is what you need. And of course, there should be more efforts towards promoting prevention. Because I know of insurers like what they have for us again in Ghana, they have this free medical checkup for everyone that wants to go for it, because they think you have to know where you are in order to improve and to prevent. But I go back to the panelists and, 3 questions: collaboration, filling the gap, and prevention. And maybe Peter, if I can start with you.
Yes. So I think the collaboration one is really important, and I think it's recognized. At the same time, I think in terms of aspirational, the comment you make, Kwasi, if you try to keep everyone on board, you will not sail out of the harbor. So sometimes you also just need to accept that there's some duplication or some inefficiencies to just get started, I think. Because that for me is the main takeaway. I think change does not just come like one night after the other, like in terms of, especially if you make things too big, you may as well sort of like really in your ivory tower design the solution. And then, you come to market after 12 months and then it remains very quiet. We've made that mistake many times ourselves as Kerpe. So I think for me, the takeaway would be to really collaborate, yes, and start small. So start small, see how it works. If there's positive traction, expand it, connect more solutions, connect other partners. But if you try to make it too big, my experience is that then you either waste a lot of resources or you will never be able to start off. So, yeah.
Thank you. Amit? Go ahead.
Yes. Yeah, I want to echo the words again. Dr. Lucy was very right, Mazaba, about collaboration. Let me start with hers. Collaboration is, and I keep saying collaboration is a new innovation. And I personally am very hopeful with the Digital Health Agency. And I'm hopeful because even in medicines, many years ago, we were talking about collaboration. We had PPB that then listed all the medicines that were going to be brought in, collaboration amongst producers, manufacturers is become harmonized. In digital solutions, we need to find a listing. You need to get listed. You need to get approved. You need to see that we can harmonize so that we may not have a plethora of many, that some of them may work, may not work. So I fully agree with you that inclusiveness and collaboration, so that we don't have many people working in silos. George, from your side, I think you're raising an important point that health is not about medicines. And when you say we've missed the boat, I think prevention is better than cure. And I also think prevention is cheaper than cure. So I think with the Ministry of Health, with Tracy being here, if we have a sustained system of also discussing digital solutions in improving public health and preventive and promotive health, which I know that all counties and national government is looking at, we might be very, very inclined to understand we shouldn't leave preventive out. We are talking about curative here. UHC is also talking about emergencies and treatment, because we can't forget that. But you're absolutely right that the mandate of preventive and promotive health and using digital apps, I saw some people talking about chronic healthcare. I saw some people also talking about NCDs. I saw some solutions about maintenance therapy. It's almost in line with what you're saying, that if you do get an illness, let's make sure it is not accelerated or exaggerated. But healthcare starts at the homestead and not at the hospital doorstep. So if we keep that in mind, then we think we'll be there. In terms of the bullet points and the gaps, sir, your question, I'm hoping Kwasi and the team, organizing team here, that out of this session, we collectively will be able to produce a report. And that report, I know, will provide input and solutions that we can revisit. I know that we have expert rapporteurs, and hopefully we'll all be able to share some key bullet points. Thanks.
Thank you very much. In terms of the gap in financing, the model that we're implementing, just to mention that as a conclusion, that we do recognize those gaps that exist in financing. And then that means that what we discussed here today as sources of mobilizing resources from all the players become very important, because in as much as we say this is the cost of the primary healthcare delivery from the government funding, we also know that that is directly related to the cost of that care. So all those interventions that we intend to put in place, including the efficiencies from digitization, focusing on the level 1 and of care from the community, also in the promotive and the preventive areas. If we can focus on that, that should mean that moving forward, the cost to deliver primary health care should ideally start to show some positive decline. But that said, we still have to keep pushing for the necessary allocation in a continuous manner, because what we had was what we was allocated at the beginning, but it's a continuous process to continue sourcing for those funds so that we can be able to meet the gap of provision of that care. When we look at the other areas, like for the health insurance, again, directly looking at ways, innovative ways of how we can bring in the informal sector to be able to be covered with the insurance. It's very critical because we're looking at about 85% of the population in the informal sector, and we need ways of how to bring them on board in terms of sustaining the SHIF, the insurance fund, because then the formal sector is very small, and the source of financing there may not sustain all of us. So innovative mechanisms then play a very key role. How do we bridge that gap for the health insurance for the informal sector? And of course, the last bit being the ECCIF, also again very related to the other two funds, because what we have financed to begin with is the emergency services, which are critical and being a right to the citizenry. But there are other components that we had envisioned, or we envisioned to mobilize resources for. And then realizing that also there are lots of components of non-communicable diseases in that fund, then they all tie together, that if we can strengthen our primary health care, our preventive promotive approach, then also that cost should be seen to decline with time, but needs also to keep pushing in the short term for allocation of resources to finance those services. And I believe it's something we can do, all of us, as it's been said, collectively, looking at all sources, a multi-sectoral approach, so that we harness all the resources that are available to us towards provision of that care. And of course, not forgetting that we do have the vulnerable populations that we also need to factor in mobilizing these resources, so that the vulnerable populations are taken care of at all the levels of care, and the resources are visible. They are allocated to the vulnerable population, so that we can be able to move forward in terms of financing the services as we have planned. Thank you very much.
Okay, thanks, Dr. Rai, for that point. I think that's probably something we've missed in a lot of the discussions. Take your point a bit further. What we lack is a number to it. The data, that's where the data aspect comes in. So when we are sitting down and lobbying for funding from Treasury into healthcare, what numbers are we giving them, saying this intervention, hygiene, and the things you've mentioned, this is the cost saving, and this is the exact number per person that healthcare is bringing to the table. Because for the longest time and to date, healthcare is still looked at as an expense center, right? Not something that's bringing revenue to the country. So it's looked at as a spend. It's looked at as a spend, and that's why, again, I will be tough on government, can get away with giving 4% or 5% of what they expect, because someone in Treasury is not seeing, if I give 5% of what I am supposed to give for the emergency fund, and we have 95% of people who get injured out of work, what is the amount of money lost because they are in hospital and they're not out there spending the money to make tax as a government from that money? So we need a number to that. And that's the number we also need to start thinking about when we are lobbying government for financing. Thank you.
Any questions from the audience? If not, we have a business delegation from the Netherlands in this audience, and they are hearing you talking about health financing of digital health. And I want to ask any of you from the private sector side, what is a key message that you would like them to reflect on when it comes to engaging on financing digital health in Kenya? Okay, so I would this has been my message. I think we as Kenya, so first looking locally before we start looking externally, the people who have spoken to digital health innovations all through have always been seeking funding from external sources, be it private equity, be it funds that have been created here and there that are financing healthcare in Kenya. Now, if you look at these funds, where do they get the money from? So if you trace the money from any fund, pick any fund that has invested into healthcare in Kenya, private equity fund, name it, this money comes from a government somewhere or a pension fund somewhere. What is the money we have in pensions in Kenya? Can anyone chance a guess and shout? What is the assets under management within Kenya, within Kenya's pension scheme as of today, last week? It's actually 2 trillion shillings. So we have 2 trillion shillings in the pension sector in Kenya, and yet we have people who need long-term financing, who are struggling because they cannot access financing. Why? Because this money is tied up here and there, and nobody is thinking, how do we finance our own country before we even start looking externally? For those who are coming in externally, the Dutch, right? My appeal would be, how then do you work with private sector to give them below market rate, for lack of a better term, funding, financing? Nobody wants, we don't want free money. All you are saying is, can we get money at rates that we can pay back easily? So if you're willing to get into a public-private partnership and establish a fund that then we can borrow from and pay back with the interest. Thank you.
Yeah, I think Dr. Okaka said it all. First, I want to congratulate the Dutch delegation for choosing Kenya, and we are very thankful that you've made time for us. There are a couple of points I want to add to what Dr. Okaka said. For the Dutch team, when you're in Kenya, think beyond Kenya. Kenya is your base, but your integration and your business would be beyond Kenya, East Africa. Number two is that the government here is created a very enabling environment. We have regulations, we have policies, and we have availability to engage national county government quite freely. So there's a true public-private partnership happening. Of course, we have challenges. That's the second thing. Utilize the existing goodwill for your solutions and your enterprise to thrive in this part of the world. Third is get the right partners. And I think that's where some of the people here can guide you. Your B2Bs that you've had in Nairobi, your B2Bs that you've had in Kisumu, I think your partnership is key. Even if it takes time, it's better be a right partner rather than being quick. So you can have a sustainable business partnership. In some cases, having local partners on the ground actually enables you to scale your solutions and to tweak it appropriately. Those are my key points.
Yeah, thank you very much. A big of applause for the partners and the panelists. And that brings us to the end of this presentation. The moderator is on my neck, so I've got to give him the microphone. Thanks a lot.
Let us appreciate Dr. Kwasi for a job well done. Pigeni makofi. Doctor, thank you very much. And the panelists, we really appreciate you. You can just join the rest of us. There you go. Your notebook and your pen. Asante sana. Now, ladies and gentlemen, we're about to transition into the final segment of our program, and this is the closing ceremony. And to be able to do that, who better to guide us in this? But before we do that, of course, I just have to appreciate, I think, our sound team. When you say that we'll finish strong, these batteries, I think, they're not working properly. So if we can get help with the batteries so that we don't burn last minute, we'll appreciate. Let's see, is that fair? Yeah, that's so it needs me to stay at a particular position, yeah? Like this. So I'll try do this. Ladies and gentlemen, I'd like to appreciate our sponsors once again. If you see me mention a sponsor, remember the discussion that we've had here about what financing? What did we say about financing? It has to be targeted, okay? That is one of the keys. So when I mention our sponsors, these are actually people who have had targeted engagement with us, and also our partners. They have enabled this to happen. So we'd like to appreciate Living Goods, Farm Access, the government of Netherlands. We really appreciate you guys, Help Entrepreneurs, Population Service Kenya, Pathfinder, Jacaranda Health, MTIBA, Smart, Luala, Medtronic Lab. This one I was given the pronunciation, but it has escaped my mind. But I will just mention the specific letters. JHPIEGO. It ends with an ego, and my ego doesn't allow me to misspell words. All right. So we have that one. We also have Center for Public Health and Development. Also, we'll appreciate our partners, and even when the mic tries to disappear when we want to mention partners, we still move on. So we appreciate our host county of Kisumu, Homa Bay County, and the larger LREP region, LEC region economic bloc. We also have the Ministry of Health, African Union, Africa CDC, Ignify, Palladium, AMREF, Wanda, AHB, that is Africa Health Business, TICO, Maisha Med, Kenya Health Federation, and also Health Informatics, Kenya Health Informatics Association, and Health X, and many more. We really do appreciate you. And before the conference ends, I'd like us to collectively appreciate our partners and our sponsors. We'll begin to Makofi for the effort and believing in this particular vision. And now to transition us into the final segment of this program. Ladies and gentlemen, tell your neighbor we are finally closing. You looked sad, I saw you dozing. Tell them, what dreams did you have? Did it have AI in it? Yeah? You think about AI and to guide us in this particular segment. And I'd like to invite the chair conference, who's also CEC Health Kisumu County, Dr. Gregory Ganda, to take us through the closing ceremony. Tafadhali mpigeni makofi hadi afike. Until he arrives. Daktari, your glasses are really, really stylish. Maintain them, okay?
Thank you very much. Yes, thank you very much. I think we will not have a ceremony, we'll have a closing session. We deliberately decided to have the conference closed before lunch because some of you have to catch flights. And so if we break for lunch, then we might not have you back here to have the ceremony. So we decided let's just have a session. But before I close, I'm going to at least recognize somebody who came with me. I see my governor recognizing his wife when he's with him. So let me recognize my daughter who is with me. Kathy, thank you. You can clap for her. Thank you so much. And let me call all the members of the organizing committee to at least step forward so that we can see them, the people who made this conference be. Where are you? Are you here? Please come in front. If you're not there, I'll move on. Thank you. This is a committee made up of several people. We had members from Farm Access, Care, Department of Health, Kisumu, Homa Bay, and CarePay. I'm going to allow you to say your names one by one before I proceed, and which organization you come from.
Hello, good afternoon. My name is Oma Onyango. I'm with Pathfinder International as the Regional Director for Research and Strategic Communications. Thank you.
Good afternoon, everyone. My name is Felix Muvea. I'm working for Farm Access in Advocacy and Communication.
Good afternoon. My name is Mero Diambo. I work with Department of Health, Kisumu County.
Good afternoon. I'm Dr. Ida Kelly from Kisumu County Department of Health.
Good afternoon, ladies and gentlemen. My name is Dr. Kizra, Department of Health, Kisumu County.
Good afternoon, everyone. My name is Francis Aila from the Department of Health, Homa Bay County.
Good afternoon, everyone. Kindly wave. Thank you very much. My name is Ochieng Gumbo. I work for the Lake Region Economic Bloc, and it's a pleasure seeing you all here. Thank you very much.
Good afternoon, everyone. My name is Caleb Majiwa. I work with Farm Access as an accountant.
Good afternoon. My name is Lorraine Anyango. I work with Kisumu County. I support health in matters of communication.
Thank you very much. You may leave. This is the team that managed to bring together all of you and get this very unique conference. And I want to thank them really from the bottom of my heart, because it was not an easy job, especially working under me, because I put a lot of pressure on them in the last 2 weeks to get this done, but I'm happy that they delivered this first unique conference of the Lake Region Economic Bloc. I'm not giving a speech. Somebody will give the closing speech. So allow me to read the communique, and I'm going to say that this is not a final communique. This is just information gathered from the last 2 days, because I know the rapporteurs needed like an hour or two to gather and create a document. I didn't give them that time. So we should be able to get a written communique digitally, probably 24 hours is okay? Yes, I think Uma was our manager. We had a conference chair and a manager, so Papa did the day-to-day was Uma. I was just the chair. So this is the communique from the Lake Region Economic Bloc, the draft. The theme was Innovate, Integrate, and Elevate for All. The Lake Region Digital Health Conference 2024, held from October 16 to 17 in Kisumu, Kenya, brought together healthcare professionals, government officials, private sector leaders, and international stakeholders to discuss the future of digital health under the theme, Innovate, Integrate, and Elevate for All. And this year's conference, which was first, addressed pressing challenges and identified opportunities to harness digital technologies in order to achieve universal health coverage, enhance healthcare equity, and elevate healthcare outcomes across Africa, and really in the Lake region. We had 280 participants on day 1 and day 2. I think day 2 had less participants by 60. We had 220 today and 280 yesterday. That tells you those 60 were most likely very high-level guests and the policymakers, because yesterday was the highest level of people, and the people who remained were technocrats. So that tells you there was a good mix of those, both those teams. The objectives of the conference and the goal of the LRDHC 2024 is to explore ways to leverage digital health innovations to improve healthcare delivery, foster collaboration, and ensure equitable access to health services for all, particularly the underserved populations. And the discussion centered on 3 key themes. One was innovation. We just crammed it up together. One was innovation, the second was integration, and the third was elevation. The opening remarks were done by His Excellency Professor Peter Nyang-Nyong'o and what was the title? The Assistant Minister for Economic Affairs from Netherlands, who was our guest of honor, or the chief guest. And they highlighted several things. I'm just going to highlight what the governor said when he opened. He called on public and private stakeholders to prioritize innovation in digital health, stating that we must ensure that digital health solutions do not serve the system, but rather the people. And our healthcare systems must be people-centered, and digital health is the key to unlocking this transformation. And so his remarks and the remarks of our chief guests set the tone for the conference, underlining the critical need for collaboration between governments, private sector, and communities to advance digital health in Kenya and across Africa. In the innovations in digital health, there were several innovations which were highlighted, but I'll just talk about 3 areas. There was artificial intelligence and machine learning, and we had several sessions which explored how AI can enhance disease surveillance and predict health outcomes. And you can remember Dr. Amit Thakur emphasizing the potential for AI to revolutionize healthcare. And he stated that AI health specialists are no longer a dream, and they are part of the solutions we need to prepare for the incoming decade. We had telemedicine, and we had Makueni and Kisumu demonstrate how they're using telemedicine. Kisumu demonstrate how they are using a community platform embedded into the primary care networks through one of our partners, Health Entrepreneurs. And Makueni showed us how they were using telemedicine in their operating rooms. We also had drone technology, and Zipline showed us how they have made an impact in several of the countries where they are working. We had several mobile health solutions, but we had speakers from Vihiga and Busia who highlighted how mobile health solutions are empowering the community motors. And we also had some talk about GIS, a unique thing about Vihiga, embedding health inside the GIS. In terms of integration and digital health and universal health coverage, the conference stressed on the importance of integrating digital health solutions into UHC frameworks to ensure sustainability and scalability. And they focused on 3 areas. 1, the data systems and infrastructure. And we had talks by Mumo from the Ministry of Health, who underscored the need for standardized digital systems, including robust frameworks for machine learning, AI, and GIS. And the Ministry of Health is developing a national digital health superhighway to streamline healthcare and data management and improve decision making. We had issues on policy and governance, where you had Dr. Joyce Wamishe give actually the opening remarks, where we learned that a strong and legal regulatory framework is critical for successful implementation of digital healthcare solutions. We also had discussions about capacity building from partners in Vihiga and Kisumu, talking about community health practitioners. In terms of elevating healthcare access and equity, this was a key theme in the conference, ensuring that digital health services elevates healthcare outcomes for underserved population. And we had several sessions discussed. I'll talk about the maternal health because I was there and because I like maternal health. And we had Wanda, Jacaranda, Farm Access, Zipline, Mom Care present to us how we can be able to work together to reduce maternal mortality. And we saw how we can sort out the issues of first delay, second delay, third delay, issues of quality in the facilities, leveraging on digital technologies to leapfrog where we are. I remember my colleague from Siaya who is here, Waziri Konyango, wondering why Kenya is behind Tanzania and Rwanda. We also touched on adolescent health, and we had a very unique platform from TICO, showing how TICO is a ticket. You can use your ticket to get health services. And this unique platform has had an impact, particularly in the underserved areas, the slum areas of Kisumu, where youth and adolescents have been given a ticket that finances their healthcare, and they can walk into a facility and get points whenever they get their healthcare and use these points to get other products from other places. We also had issues of gender equity and digital health. That was a special session focusing on women's participation in digital health leadership. And we had that session on women in digital health, where we discussed the needs for mentorship programs, human-centered design, and partnerships to ensure that digital health solutions address the unique needs of women and girls. Ladies and gentlemen, we had several challenges and next steps which came out from the conference, but I'll not read all this that has been put here, but there were following key actions that came in. First of all, the challenges focusing around inadequate infrastructure, limited access to reliable energy, internet, and insufficient investment in digital tools. And as a way forward, there were three key actions. One, strengthening collaboration, building capacity, and developing clear policies. All this will be outlined in the final communique, which will be done within the next 24 hours. So in conclusion, the 2024 Lake Region Digital Health Conference was a pivotal event in advancing the digital health agenda in Kenya and across Africa, and particularly in the Lake Region. A lot of people like talking about Kenya. By innovating, integrating, and elevating digital health solutions, we can transform healthcare systems and achieve equitable healthcare access to all, emphasizing, and as emphasized during this conference, the future of healthcare in Africa is digital, and it is essential for the region to harness this potential to improve health outcomes and build resilient health systems for the future. And as I close, this was the first. We are hoping that all other counties in the Lake Region Economic Bloc, this was hosted by Kisumu and co-hosted by Homa Bay. We hope next season we'll have Migori being the host and get another county to co-host so that we have this convergence every year. It has been a time to learn. I know my colleagues have talked to several partners. We have seen things that work. I've seen my colleague trying to catch up with a few partners who are working here. I know we got people from other counties, Makweni, who also found very interesting things that he wanted to go and take back home. And that is what devolution is all about. Devolution is about innovation and sharing innovations and getting a platform for that. And I think this conference succeeded. So ladies and gentlemen, let me say and express my gratitude again, my sincerest gratitude for all the partners who made this possible and for trusting us with this, for having faith in us that you could actually finance us to deliver this. And I think it was delivered well. What do you think? Do you think it was done well? Yes, so a round of applause to all of us. Asanteni sana. And it is now my honor and pleasure to welcome a colleague of mine and somebody I respect, a great administrator whom I've decided to honor with this opportunity to close the conference, the CEO of our Level 6 Hospital, Dr. Lesiampe. Dr. Lesiampe does not need introduction from me. He has done several things. He has been a PS, he's a manager, he's a leader, he's a trainer, and so many things. So I give him this opportunity to give his remarks and officially close the conference. Thank you, sir.
Good afternoon, everyone. Yeah, my name is Richard Lesiampe. I'm the CEO of Jaramogi in Kisumu. I'm 7 months old in this region. I'm greatly humbled by my CC to me. He's actually my senior. It is very rare, to delegate authority upwards. In fact, it's supposed to be delegated downwards. But I think I really appreciate that with a lot of humility and a lot of respect. It makes me very awkward, actually, to close this after he has spoken. But let me just make a few remarks. Yesterday, I didn't make it. I was out of town. And I actually called him and told him that I'll definitely make an effort to come to this conference. I'm coming here because, one, I'm in the health sector now. My other experiences in the past was when I was the CEO of Kenyatta National Hospital. At that particular time, Professor Anyang' Nyong'o was the Minister for Medical Services. As he has told you, I'm actually an administrator and non-medic. My PhD is in strategy and change and transformation. And my first degree is in public administration. It happened that I worked for Kenya Wildlife Service for about 15 years, taking care of wildlife. I really enjoy it. I really remember Kenya Wildlife Service, a lot of nostalgia, because these animals never complained. They never went on strike. They always waited for our instructions. But it happened that Professor Anyang' Nyong'o took me to Kenyatta National Hospital, and the joke in town when I became the CEO of Kenyatta National Hospital was that the staff of Kenyatta National Hospital was so difficult that they needed somebody from wildlife to manage them. But that's not true to JOTRH. I've come to find a team, a great team of experts in in health, great doctors, great consultants, great nurses, great healthcare workers who are doing everything possible to provide excellent clinical outcomes for our patients. I come here also to really appreciate the health workers of this country, and particularly of Kisumu, and also of this block. For record, these are the best men and women we have in our nation. In fact, our academic system clearly shifts them, distills them, that you can only become a doctor if you have an A+. You can only become a nurse if you have an A or a C+. Indeed, during my time, and in fact, and I'm really worried when I hear about digital highway, I was born in BBC, born before computers. I'm actually a grandfather sitting next to a grandmother here. We used to respect doctors and nurses because, one, they had to get what we call an MPC, mathematics, physics, and chemistry, and biology as a rider. They were the best. And indeed, as we speak today, they are still the best human beings we have in our country who help this nation to restore health to our people, to ensure that, they touch those who are sick, and ensure that we are all strong and healthy to produce and actually perform in our economy. And therefore, these are the people now, when it comes to digital health, these are the people we need to look at. They are very brilliant. They are sharp. Why don't we give them the gadgets? Why don't we give them the equipments? Why don't we give them the competencies? Why don't we give them every possible commodity that will help them, use these digital equipments? Sometimes we look at digital equipments. We are talking about telemedicine. I remember I, in fact, initiated the telemedicine department in KNH. And our first telemedicine exercise was between KNH and Apollo hospitals in India. In fact, we also tried to go local. We tried to do telemedicine between Kenyatta National Hospital and Machakos District Hospital then. I don't know whether they've continued with it. But what is very critical and important is not only the equipments, it's not the computers, it's not the tablets, it's not, in fact, the teleview, as we call it now. It's not the screen view. I know all those gadgets are critical and important in telemedicine. It is the person, it's the human being. It is this doctor, this nurse, who handles those equipments. And therefore, as we close this important conference, let's consider that telemedicine and particularly artificial intelligence will take us very far. Will indeed create great clinical outcomes. The speed of handling our patients, the speed of getting diagnostics done, the speed of collecting data, the speed of analyzing that data, analytics, the speed of using that data, in fact, even to raise funds. It's going to happen. But at the end of the day, the doctor-nurse intervention must always be there. And therefore, that element must be considered. In fact, I want to just give an example. The last 2 or 3 days, I think the last 1 week or so, we have had challenges with the SHA. And one thing is that personally decided to go through the exercise to see exactly what are these challenges with this system. I want to tell you here, no one has actually told me to talk about it, but I came to realize that SHA system was actually very fast. In fact, it came on 1 or 2 things. Pre-authorization, particularly for surgery, took actually 30 minutes, while I used to wait for 7 days, 21 days sometimes to get pre-authorization. I actually decided to take through a patient, a chemo patient. It actually took 3 minutes to get pre-authorization, to get authorization to have that patient going to lab. I'm talking about it, that digitization and automation is actually very, very critical to help our patients. I don't know what will happen after this. I'm waiting to see whether I'll be reimbursed in the next 30 days, all those services. But I have the confidence that this is going to happen. I think when it comes to digitization, and I think also when it comes to artificial intelligence, I think that is the way forward. And I want to call upon the Kisumu, particularly the Kisumu fraternity, or of course the Nyanza block, that we need to sit together, having come with some resolutions here today, that a patient who goes into one of our facilities should actually be assessed there, and when they come to JOTRH, we have no other reason to collect any other data, to collect any biodata, that we can indeed continue with interventions, continue with treatment, just by doing other further investigations. I think this is something that is possible and it is workable. It also brings me to 1 or 2 things that we have done at JOTRH. In fact, as I conclude, one, at JOTRH, we have decided to automate our systems. In fact, as we speak now, JOTRH is automated from registration, triage, labs, imaging and diagnostics, X-ray. In fact, by the end of next month, we will actually have finished on automating inpatient services. We are going to be paperless in the clinical areas before Christmas. And we have realized that within that short period, we have indeed, to some extent, doubled our revenues and made great clinical outcomes and speed in handling our patients. 3 weeks ago, we decided to go on laparoscopy surgeries. And with laparoscopy surgeries, we also decided to go on what we call screen viewing, where the surgeries were being conducted at the same time were beamed to a simulation room for our students from Maseno, Uzima universities. This is actually great. We intend to continue with the laparoscopy surgeries. We have got trainers from Nairobi. We have got also consultants from Nairobi assisting us in these areas until come next year, January, 60 to 70% of operations or surgeries will be conducted through laparoscopy. Finally, we have developed and formulated a strategic plan. We call it a strategy for GOTRH. This strategy has been integrated with what we call balanced scorecard approach. It is the latest in terms of ensuring that a strategy is executed and implemented. I think in history, we all know only 30% of strategies are executed in the public sector. For us, we want to be different, that we are going to execute almost 80% of this by using balanced scorecard approach. Balanced scorecard approach requires that we develop also a dashboard. In fact, an automated, digitized dashboard. That sitting as a CEO, the CEO of GOTRH, wherever I will be, anywhere on earth, I can actually tap with a button to see how many patients have been operated in a day within my department, my hospital. I can actually tell how many patients have paid for their services. I can actually tell how many patients have been declined, maybe have not been taken to theater. That is the direction we want to take. And therefore, as I conclude, we want to call upon all partners. We want to call upon collaborators. We want to call upon other agencies and in fact embassies. That we at GOTRH and in Kisumu County, to be more specific, we want to engage. We know we can only get clinical outcomes with partners. That we can only fund healthcare with partners. That we cannot only rely on government, for funding in health. And indeed, I think my CEC has said it, and I want to put on record that we are the only level 6 hospital in this country that is being funded by a county government. I don't know whether that is positive or not positive, but indeed, we are very proud to be associated with that. In fact, we are also very proud to say that you are the only county in this country that the governor is a PhD holder, a professor. The deputy governor is a PhD holder, a doctor. The CEC Health is a PhD, is a doctor. The speaker is a PhD holder, and the CEO of Jaramogi is a PhD holder. Therefore, I want to end saying that all the resolutions made here, all what has been agreed upon here, we are going to ensure it, Waziri, that we are going to form a caucus, we are going to form a colloquium, we are going to see how best we can actually engage within the bloc and also to get other partners from outside. It's with partners that you survive. You either have partners or you perish. And indeed, at GOTRH, we want to become the best referral facility, not only in Kenya, but actually in East Africa. May God bless you, and officially close this conference. Asanteni sana.
Thank you very much, sir. Pigini makofi tena. That's amazing. Ask your neighbor, does your governor have a PhD? At this particular moment, congratulations, sir. Does your MC have a PhD? This particular moment, I'd like to hand over back to the conference chair for a short remark before we now disperse. Sir, to you.
Thank you. Usually you don't close and open again, but I forgot to recognize the role of my CHMT, led by Dr. Juang Lucy, our chief officer, Makofi kwake. And other CHMT members who are here, please stand up, raise your hands. Stand up, Mukonekane. Yes, I have a big team. Yes, these are all my divisional and departmental heads in the county government of Kisumu. Thank you very much. And thank you for your role in making this happen.
Thank you very much. So, at that moment, since your faces are bright, yeah? You've had, now we've closed, we're going home. Some of you have missed your children. Thank you very much, sir, for introducing your daughter. Even me, I'd like to introduce my, the next session of... So, we want to have a short picture moment. Remember, this is the inaugural, yeah? And it's been amazing. We'd like to take photos, and I'd like, first of all, to call the people that have been privileged to sit at the front. Just come. Then the rest of us will come and fix ourselves somewhere. Can I get some help to get rid of these things off the stage? We want all of us, and make sure you appear on this photo. Evidence is critical. I know you will be asked, you are in Kisumu, where is the evidence? Okay? You can always produce this photo. So let us move all these things off the stage. Then we have our chief guest conference chair. Of course, help me with your very able chief guest at the front to come and join us here. Do you prefer to stand down or on the dais? You guys can be here. Then the rest of us, if you can have a couple of you come, the confident ones, or I can come pick by myself since you look very picture friendly, sir. Okay, let's go. Let's have some people on top. We want to take a group photo, a very nice group photo for all of us. The rest of us, let us join on top. We have some space on top. If you appear right behind the conference chair, you're the next conference. Oh man, now you're moving. Okay, let's move, fill that space. Guys, come on. Let's move a little bit faster. Thank you very much. Wow. That stage is designed to take that weight. And if at all something happens, I can't confirm nor deny. Let's join in. Now, sir, you're a genius. You're a genius. Pick a chair and just come and sit here. Pick a chair. Don't feel, nobody will massage your shoulders. Yeah, don't you worry. Let's have a chair here. Okay, let's move that one a little bit. Okay, there we go. Some more chairs. I love this. Okay. All right. So we will exercise the power of cropping when it comes to this photo. So I've been told, wonderful lady writes glasses, that is the cutoff. So sir, if you don't appear on this photo, it will be a problem. On this end, I'm being told who exactly? Here. So what are you saying about the rest of the people? They can come for the second line of chairs. And how will this person appear? Can you squeeze further? Is there an option to squeeze further? Or can you take a panoramic photo like this? Okay? Sawa. Because if, I'm Gen Z, I could easily do this here. But it's not as flexible for many people. I'm meant to understand. If you're younger than 25, come. No, we can't do that. All right. Ladies and gentlemen, cameraman, you will fix the rest of the people post-production. I want you guys to smile. Okay? I want you to smile. Imagine you're serving your favorite dish. Yeah? Just imagine. As you look at that. Look at that. Imagine you're meeting your daughter now. You've gone back home after 2 days here. Oh my, you can't relate. Okay? Yeah. Imagine. Have we gotten a nice photo? Have you gotten a nice photo? All right. So, one more request, okay? And this one will say all of us. Since this Digital Health Conference 2024, it's a wrap, okay? We'll say it together. Digital Health Conference 2024, it's a wrap. Sawa. All right, I know some of you schooled during Arab Moi. No, you can use that still, okay? So, are we ready? Video, are we ready? Okay, ladies and gentlemen, in 3, 2, 1. Okay, somebody has started like ladies and gentlemen. So, I'll give us one more chance, okay? So in 3, 2, 1, it's Digital Health Conference 2024. It's a wrap, okay? All right. And if you can use your hand slightly, if you're not squeezing, you can say, it's a wrap, okay? Or you can say, it's a wrap. Or you can say, it's a wrap, okay? Right. In 3, 2, 1. Digital Health Conference 2024.
It's a wrap. Appreciate yourselves, guys. You've done amazing. Amazing. And it's at that position that we close our wonderful conference. My name is Nwakip Kimboy. I always make conferences fun. Appreciate your neighbor even as you walk. Don't walk alone. We are all Liverpool fans. We are serving lunch by the pool. Okay? And even as we do so, I'd like to remind you that Zipline is offering some amazing experience. Zipline